Hello, my name is Ann Gaffey, and I am currently the second year fellow within the Division of Vascular Surgery and Endovascular Treatment at the University of Pennsylvania. I'm thrilled to be invited back here again to discuss with you all vascular disease and vascular surgery. We will be going through the general vascular concepts as well as how to take an adequate surgery history and physical, and then we'll be working head to toe in the discussion of arterial disease, and last but not least, we will be discussing venous disease. So first, let's just get this started on the basic pathophysiology of progressive vascular disease. So when we're thinking about the arteries and the vessel walls, there are three layers to the arterial wall. There's the intima, the media, and the adventitia. Now, when we look at the intima, that is what ultimately is what we're seeing on the inside of the vessel. And when atherosclerosis affects it, arterial bed, it's generally within the media. So there is a lymphocytes that deposit upon the intima, and then macrophages go within the media and ultimately form what we know as the plaque. Now, in general, when atherosclerosis occurs, the most common locations are either at the ostia or the beginning of blood vessels, so that's most relevant in the renal arteries, and then at the bifurcations. So whether that's the aortic bifurcation, the iliac bifurcation, the common femoral bifurcation, or the carotid bifurcation. So when we think about when does atherosclerosis ultimately result in disease, we have to think of it resulting in a critical stenosis. So going back to the law of Puceau, you think about critical stenosis and the degree of stenosis that's required to produce a reduction in blood flow. So as you can imagine, when you have about a 50 to 70% reduction in the diameter, it results in a significantly higher reduction in the area, simply based upon pi r to the fourth degree. And as a result, the energy that is lost across a lesion depends more on the degree of stenosis or the narrowing of the true lumen than the length of the lesion. So as a result, if you have a long, about 50% reduction, that may not result in any type of clinical impact of the degree of stenosis. However, if you have, a short segment of near total occlusion, that then may be very significant and have a very significant clinical impact for the patient. These lesions that we describe as subclinical may only become symptomatic during exercise, and we'll get into more of that when you're taking the history and physical. The other thing that's important is when you think about the total resistance or the impact of disease, it is additive across vessel beds. Therefore, energy that occurs over multiple vessel beds will oftentimes result in a more significant stenosis. So that's why we talk about aortoiliac disease or iliofemoral disease or tibial disease and so forth. Depending upon where a lesion occurs, collaterals may develop. When we think about the risk factors for atherosclerosis, the most common are age, so increasing age, gender. It's primarily more prominent in men, although women have a specific degree of atherosclerotic disease that can develop. Having a family predisposition, hyperlipidemia, hypertension, cigarettes, diabetes, sedentary lifestyle, type A, stress, obesity, and so forth. So that gives you some basics upon atherosclerosis, which is one of the primary disease pathologies we deal with in vascular surgery. And the other one we deal with are aneurysms. Now, aneurysms are a focal dilatation of the vessel that is 50% larger than the normal expected artery. Now, when we think about normal arteries, it's dependent upon both the gender of the individual as well as the height of the individual. So, for example, a normal aorta is about 2.5 centimeters, and we describe it as ectatic or enlarged when it's greater than 3 centimeters. However, it is not until it gets to about 5.5 centimeters that we result in any intervention. However, that threshold may be lower if it's in a small, petite woman. We may be more willing to intervene when her aorta reaches, 5 to 5.3 centimeters. The risk factors for aneurysms are atherosclerosis, high blood pressure, diabetes, cholesterol, smoking, hereditary, which is oftentimes resulting from a connective tissue disorder, excuse me, as well as a bicuspid aortic valve, injury, or infection to the aorta. Now, there are multiple different types of aneurysms. So a healthy vessel is true lumen, and you see actually nice laminar flow throughout here. Now, when we talk about a true aneurysm, and a true aneurysm occurs in all three layers of the vessel wall, as you can see here. There can be a saccular aneurysm, which is almost an outpouching, or a fusiform, which is a diffuse aneurysmal dilatation of the artery. There can also be dissection aneurysms, and we'll talk about that when we go into acute type B dissections, and then false aneurysms, otherwise known as pseudoaneurysms, and those only occur within one layer. So the intima and media are intact, but the adventitia is what results in an outpouching, and because it is a thin vessel wall, these are emergencies. Now, when you're taking a physical exam for a vascular history, it's important to do a full cardiopulmonary exam, assessing for evidence of arrhythmias, primarily AFib, any murmurs that would lead you to believe that the patient has aortic stenosis, or rubs if they have any sort of evidence of valvular disease. You want to do a full neurological exam, examining all cranial nerves, and a thorough motor sensory exam as well as coordination. When you're looking at the lower extremities, you really want to assess what the skin appearance is, to assess for edema, any loss of hair, or tissue loss or open wounds. When you're assessing the pulses, you want to determine bilateral brachial pulses, palpate to assess. We oftentimes use a scale of 0 to 2 plus, 0 being non-palpable, and 2 plus being normal, and greater than 2 plus being aneurysmal. We oftentimes feel for a carotid pulse, brachial pulse, radial and ulnar, femoral, popliteals, dorsalis pedis, as well as posterior tibial. You want to listen for bruits, and you'll oftentimes hear a primary care physician refer a patient because they heard a carotid bruit, which may suggest that there is stenosis. Look for ischemic changes, as we talked about in the lower extremities, shiny skin, hair loss, dependent rubor, or pallor on elevation. And then palpate the patient. Palpate their abdomen to assess for abdominal aortic aneurysms, their femorals and popliteals. Now that I've sort of introduced to you all how do we assess these patients, the question remains, how do we fix these problems? Well, as vascular surgeons, we often describe these ourselves as plumbers. There are multiple different ways we can intervene. We can clean out the pipes, which is known as an endarterectomy. We can reline the pipes, which is often an endovascular stenting, or we can build new pipes, which is open surgery with bypasses. So now we'll get into the basic tenets of vascular surgery going head to toe. So first we're going to start with carotid. So carotid disease, and in particular stroke, is the second leading cause of death worldwide. Of note, this is based upon data that's about 5 years old, and certainly there are increasing incidences of death, whether it's from overdose or from COVID, that are sort of relevant here, but I will not get into those details. In general, in the U.S., there are about 750,000 strokes per year. Up to 15% are fatal, but the most concerning are those that are severely disabling for someone having a major hemispheric stroke. 80% of strokes are ischemic in nature, and about 2/3 of those are related to carotid occlusive disease. The other third are primarily related to embolic disease as a result of an arrhythmia of the heart. So when we think about carotid disease, prevention is key. And so the Society of Vascular Surgery recommends that we intervene on all patients who have evidence of carotid stenosis who are symptomatic, meaning that they've had a stroke or they've had a TIA, transient ischemic attack, which is, a change in their neuroexam that is present for less than 2 minutes and resolves within 24 hours. Asymptomatic patients are those who have evidence of a carotid bruit, and we would intervene if they're greater than 60, have hypertension, coronary artery disease, or if they have other significant risk factors. So when we decide to intervene on a carotid, it's important we get excellent preoperative imaging. Duplex ultrasound is the good first-line imaging technique. It is really important because it doesn't provide any ionizing radiation, and we're able to assess the velocities within the common carotid, oftentimes the arch, aortic arch, and the internal carotid artery. When we get a duplex ultrasound, what we're primarily looking for is the ratio of the internal carotid artery to the common carotid artery ratio. Once we see that there's evidence of, about greater than 75% stenosis, we will oftentimes proceed with getting a CTA or CT angiography, because this is important in giving us sort of the anatomical lay of the internal carotid artery and when the blood vessel returns to its normal caliber to determine what is the best role for intervention. If a patient is unable to tolerate a CTA because of, baseline chronic kidney disease, we may have to proceed with an MRA. Last but not least, we can do an angiography, which is an invasive operative intervention where the patient will need to be lying supine, and we would need to look at their hyoid vessels. However, there is a significant risk of intraoperative stroke of about 1%. So once we have all these imaging information, we can then determine what the role of surgery is. So currently, one treatment option is optimal medical therapy. So what that involves is ensuring that the patient is on an antiplatelet agent, whether that is aspirin or Plavix, a statin, and then controlling their risk factors. So making sure that they are no longer hypertensive, that their diabetes is under well controlled, and they have stopped smoking. Now, we can proceed with doing surgery, and we'll talk about, the two different roles of a carotid endarterectomy versus a carotid stent. But when we have this discussion with the patient, it's important to ensure that the risk of perioperative stroke is less when we do the intervention than would be if we did not intervene. So the risks for carotid surgery are not insignificant. Primary risks are perioperative stroke, hematoma, cranial nerve injury, heart attack or MI, and site infection. The benefits are that it prevents future neurological events, but there's currently a large multi-institutional study that's looking at the benefit of the introduction into statins within medical management for carotid disease, and that's called the CREST-2 trial, and we're waiting for the results of that, which should be published in the next year to two. The importance of carotid surgery and before you intervene is you want to have a preoperative assessment. So you want to know what the neurological exam is and discuss what you should be doing to ensure that the brain is properly protected during the operation. So for all those of you who are wanting to go into surgery, we're now going to discuss how do you do a carotid endarterectomy. So here, what you do is you make a transverse incision along the anterior border of the scalene muscle, and then you dissect down, identifying important structures that are in the neck. In particular, you're looking for the vagus nerve as well as the jugular vein, which will ultimately lead you to the carotid artery. When you're identifying the carotid artery, as you can see here, here is the internal carotid artery, okay? Up here, this is the external carotid artery, and the way you can tell the difference is the external carotid artery is the one that gives off the branches. So here is the inferior thyroid artery that will be supplying the thyroid. And then this is the common carotid artery. As you slowly dissect this down, you're able to isolate all of the blood vessels, and then you can proceed with your endarterectomy. This is normally what the plaque looks like as you remove it from the carotid artery. And then what you need to do is you need to close the artery. So in order to proceed with closure, we oftentimes do a patch angioplasty. And there are multiple different sort of patches you can use. You can use Dacron, you can use autologous vein, or you could use a bovine pericardium to ensure that you don't narrow the blood vessel. Now, once you complete your carotid endarterectomy, it's important that you assess the patient and ensure that their neuroexam has returned to what their preoperative baseline was. And so this is what we sort of discussed earlier on, that it is essential to know if the patient has any deficits from a prior stroke. So for those of you who may be taking care of vascular patients, what you want to do is if they develop a new deficit in either the operating room or in the PACU, you'll oftentimes put the patient back to sleep and open the incision and explore the internal carotid artery. You want to make sure that there was no sort of flap that could be causing the patient to have decreased perfusion to their brain. You want to get intracranial images to ensure that there is no evidence of distal emboli that have broken off from the plaque. Ultimately, you may need to redo your carotid endarterectomy and redo your patch angioplasty if you identify a defect. If the patient is on the floor and they develop a new neuroexam deficit, you want to immediately get a duplex ultrasound to assess whether there's evidence of flow disruption to the internal carotid artery. Proceed with a CT of the head to ensure that the patient is not having a brain bleed. And then if that is the case, you can immediately take the patient to the operating room and perform an angiography to ensure that you don't need to do any additional interventions. Additionally, as we discussed, you can have complications after carotid endarterectomy. The most common cause of complications are cardiac events. Up to 50% of patients who have a need to undergo a carotid endarterectomy do have evidence of coronary artery disease. The other major thing that people are concerned about are the cranial nerves. So those can oftentimes be transient, but they are sort of detrimental to the patient and oftentimes their quality of life for a period of time. They occur in about 5 to 20% of the patients. The most common injury is from the hypoglossal nerve, which will result in tongue deviation. And as you can see here, this is the hypoglossal nerve up here. That's right above the digastric muscle, and here is the internal carotid artery. And oftentimes when you're retracting up, you can cause a retraction injury. Additionally, you can have hemodynamic instability from dissecting around the carotid bifurcation, which can result in baroreceptor hyperactivation. This normally resolves within about 2 hours after the operation. You can also have persistent hypertension, and the concern of that is that it can result in cerebral hyperperfusion syndrome. So you need to be aware of that. If a patient after they have a carotid endarterectomy has a severe new onset headache, you need to almost immediately think of this and proceed with getting a CAT scan. Lastly, you can develop recurrent stenosis, and that occurs in about 5 to 22% of the patients. So it's important after you perform a carotid endarterectomy that you do obtain interval ultrasounds to ensure that there's no elevated velocities. If a patient is not amenable to a carotid endarterectomy or an open operation, you can consider doing a carotid artery stent. So the most important thing when you are thinking about placement of a carotid stent is thinking about the landing zone. So this is an intraoperative angiogram, And as you can see, here's the common carotid artery coming up. It is proceeding to the internal carotid artery here, which is normal. And you can tell once again that it's the internal carotid artery because it's not giving off any branches. And here, just distal to the bifurcation, you can see the lesion. Now, we can identify that this patient would potentially be a good candidate for carotid end artery stenting simply because they have a good landing zone in the common carotid and in the internal carotid artery. Now, there are two specific types of carotid stenting. You can either have transfemoral carotid stenting, CAS, or TCAR, which is transcarotid artery revascularization, and I'll go into the details about that. But when these should be considered compared to the gold standard of a carotid endarterectomy are for patients who have hostile necks. So that could be for patients who have contralateral carotid artery occlusions, if they've had prior neck radiation from head and neck cancer, radical surgery, if they have a history of a tracheostomy or stoma, if they have a contralateral laryngeal nerve palsy, because you want to make sure that you don't obstruct their airway. Oftentimes, if they have restenosis after a prior carotid endarterectomy, you would proceed with either a TCAR or carotid stent. High lesions that you may not be able to get to via an incision, or low lesions that would require thoracic exposure. So when you're thinking about a transfemoral carotid stent, it's important to ensure that the patient is on antiplatelet therapy, particularly Plavix, prior to the operation. Because you enter through the femoral arteries, it's important to evaluate the aortic arch anatomy to make sure the patient doesn't have like significant atherosclerotic disease where you could be embolizing and, risking a perioperative stroke. The issues with carotid artery stenting, as you can see here, is there is the lesion, but before you can treat the lesion, you actually have to cross it. So over the past 10 to 15 years, there's been development of what are known as distal embolic protection devices. So it's a little umbrella that you move past the evidence of the carotid disease, and then you land in the normal part of the internal carotid artery and deploy. This ensures that anytime you cross the carotid lesion with any wires or stents, that you protect any of that plaque from embolizing distally and causing an embolic stroke. Now, over the past 5 years, there's been the new incidence of what's known as TCAR, or transcarotid artery revascularization. So this is a benefit because you actually cut down, you make a small incision just above the clavicle and cut down on the common carotid artery, and then you actually reverse flow through the common carotid, so it goes up the contralateral side across the brain because of the collaterals and anastomoses through the circle of Willis, and then out, and you're able to filter it through this nice little filter, ensuring that there is no flow across the carotid lesion while you're stenting. And this has been shown to really decrease the incidence of perioperative stroke for those patients who undergo carotid stenting. So when we think about carotid stenosis, and what I want you all to take away from this is that the surgical treatment, or CEA, has historically been considered superior to medically treated patients for those patients who have 50% stenosis with symptoms, meaning they have a symptomatic carotid disease, or 70% of patients who are considered asymptomatic. As I discussed, all the studies are based upon treatments prior to the advent of statins, and so there's currently the CREST-2 trial that is going on, and we are awaiting those results. About half patients report TIA symptoms prior to a stroke. So patients who come to you with complaints of word difficulty finding, or saying, oh, I've been having these vision changes, you need to think and make sure you're evaluating their carotids. As we know, asymptomatic is an incidental finding. Symptomatic, you want to intervene about 2 to 3 weeks after a neurological event. And the ways to repair this, as we've discussed, are carotid endarterectomy, carotid stents, transfemoral, or TCAR. Now, as we move on through our vascular beds, we're going to go to the upper extremity. In particular, we're going to talk about thoracic outlet syndrome. So the thoracic outlet occurs in the upper extremity, as you can see here, and it is where your axillary vein is, your axillary artery, and your brachial plexus, okay? And it is when you can have compression between your first rib and your clavicle that it can result in either neurological thoracic outlet syndrome, venous syndrome, or Paget-Schroeder's disease, or arterial syndrome. As you can see here, neurologic or neurovascular thoracic outlet is the most common. It occurs, as you can see, there's also the anterior scalene, and these muscles, and particularly patients who have repetitive motion, whether it's swimmers or baseball players or golfers, of their upper extremities can have hypertrophy of those muscles, and those can also cause compression. So when we think about management of thoracic outlet syndrome, we first want to determine what the etiology is. So you have compression, and whether that's from a muscular etiology or a bony etiology. Will then determine kind of how you want to proceed. So if it's of a vascular etiology, the patient can have compression of their subclavian vein, resulting in edema of the upper extremity, venous dissension, as we discussed, known as Paget-Schroeder's disease. It's of the subclavian artery, the patient can complain about claudication in their upper extremity. So their hand can feel weak after repetitive motion. They may also tell you that every once in a while they have sort of numbness in their hands and coolness or pallor, which can be from short segment occlusions, or these patients oftentimes have pseudoaneurysms that develop there with thrombus that can embolize distally. The patients can also have neurogenic thoracic outlet syndrome, resulting in Raynaud's phenomenon or pain or paresthesias in their upper extremities. It is commonly diagnosed through a chest x-ray, Doppler of the upper extremity to look at the veins and arteries, and then either an angiogram or a venogram. So up here, you can see that there are cervical ribs or an extra rib that occurs between the clavicle and the first rib, and as a result that causes compression of the subclavian artery vein or brachial plexus. Dependent upon what the etiology is, you oftentimes want to remove the cervical rib, first rib, or do a scalentectomy to remove any compression on whatever is being compressed, whether it's the artery, nerve, or vein. So you can see here, this is a case we did where you can see the subclavian artery right here. Up above, you can see the subclavian vein. And then this is the brachial plexus, which is nicely skeletonized, ensuring that we have not resulted in any injury to the vessels or nerves. So when we think about the surgical treatment, there are multiple ways that you can access the thoracic outlet. So depending upon what the symptomatology is will determine your access. So oftentimes for patients who have arterial or neurogenic, you want to make a supraclavicular incision, as can be seen here, and you're able to dissect down and clearly free off. For patients who oftentimes have venous disease only, you can either make an infraclavicular approach, or you can access it transaxillary just below the armpit hair. The advantage of the transaxillary are that it's very rapid exposure. For these patients, it's often cosmetic. If they're young, they will not have a scar on the chest. It also reduces injury to the associated brachial plexus and artery. The most common postoperative complications are pneumothorax, so it's important to get a chest x-ray postoperatively. You can have nerve injury, so in particular the long thoracic nerve can be injured when you're removing the middle scalene, and this can result in wing scapula, so ensuring that you protect that. not injuring the intercostal brachial nerve, which can result in numbness on the medial aspect of their arm. And then in particular, if you do a supraclavicular approach for arterial or neurogenic TOS, you can result in thoracic duct injury, which can result in a lymph leak.